Okay, so we are going to talk about hypercoagulation. And this is when we would clot too fast, clot too much. And the big thing that occurs here is we have risk for thrombus and vessel occlusion. So, there are two types of hypercoagulability states, and they're caused by two different things. Either conditions that increase platelet function or conditions that cause accelerated activity of the coagulation system. So, increased platelet function, we get clots, we get disruption of blood flow, and this is called thrombocytosis. And the main characteristic of this is greater than 1 million platelets that you'll see in lab. Causes are iron deficiency anemia. If someone has a splenectomy, because remember, when we have a splenectomy, a third of our platelets are stored there, and that's where they undergo apoptosis and such. Cancer can cause the same thing, as well as chronic inflammation. Another thing that can cause it is the atherosclerotic disease. So when cholesterol and plaque and things like that attach to the inside of the vessels, the endothelial believes that it's under attack and therefore does its thing like it does in the coagulation cascade, and we get increased platelet adherence, and those platelets keep adhering to each other until we eventually get a clog or someone has a heart attack. The next one are myeloproliferative disorders, and the main one that we're going to talk about is polycythemia vera. And that is basically an increase in our red blood cell mass, increase in our white blood cells, and a decrease in our vascular fluid. So we've kind of lost the fluid that those things are floating in around, and now it's just our blood becomes thick and sticky and just not conducive to life. So increased clotting activity. We don't want increased clotting activity, obviously, because we can have thrombus formation. These things are usually genetic and affect coagulation components of our clotting process. And it's usually a mutation in factor V, and that's what we call the factor V Leiden. And it predisposes people to thrombus and DVT, especially women in pregnancy. Acquired, we can get this secondary to things such as prolonged bed rest for people who are ill, sickle cell anemia. We already have deformed red blood cells and stasis in sickle cell. Birth control, women on birth control or pregnancy, as well as heavy smokers. And then we have something called antiphospholipid syndrome, where we have negatively charged phospholipids, which increases our coagulability, and this is usually associated with lupus. So bleeding disorders, we have platelet disorders, and one of our platelet disorders is called thrombocytopenia, and this is characterized by less than 10,000 platelets. And we can have this for a number of reasons. One is that we have a decrease in production of platelets. Another is a decrease in platelet lifespan. We can have pooling of blood in our spleen, or we can have a dilation of our bloodstream. A decrease in production would be caused by loss of bone marrow function, like a severe anemia, bone marrow infiltration, such as leukemia, or bone marrow depression, such as radiation or chemo or HIV. We could also have a decreased lifespan, which would be immune or it could be non-immune, and it's just the over-destruction of our platelets. And one of the classes of this is what we call ITP, or immune or idiopathic thrombocytopenia purpura. This is autoimmune, and it destroys the platelets via the antibodies. It can be chronic, and usually when it's chronic, it's in adult women, but it can also be acute, and that's usually seen in children. So platelets are basically covered with antibodies, and they don't look like themselves, so the spleen thinks that they're foreign, and therefore the spleen kills them. Usually the treatment for this is splenectomy, but obviously we know that there are issues with removing the spleen. However, if it's not done, these platelets start to clump together in small vessels, and ischemia occurs, which causes renal failure, heart attack, and stroke. And this needs to be identified fairly quickly because people usually die within about 3 months. TTP is the next one. And that is thrombotic thrombocytopenic purpura. And basically what happens is when someone gets a bacterial infection such as E. coli, toxins are released, and then the endothelial lining is damaged and basically goes into its cascade, and we have widespread thrombus. And this usually is a sudden onset and can be very fatal. We obviously want to stop the platelets from clumping. Our treatment, if we catch it early enough, can be fresh frozen plasma or something called plasmapheresis, which is a machine that we hook up and we remove the plasma from the blood and replace it with new plasma or fresh frozen plasma. So some of the things that we can see, some clinical manifestations, and they're on page 275, petechiae, bleeding, blood blisters in the oral cavity, obviously fatigue, purpura, and ecchymosis. So for impaired platelet function, a lot of times it's an inherited disorder such as von Willebrand disease, and we talked about the von Willebrand factor before. So this disease is a defect in platelet function due to the lack of von Willebrand factor and a decreased amount of factor VIII. It's an autosomal dominant trait. And factor 10 is not triggered in that clotting cascade because we have a decrease of factor VIII and a decrease of that von Willebrand, therefore giving us a decrease of platelet function. Hemophilia A is the next one, and that is a decrease in the amount of functional ability of factor VIII. So again, factor X or factor 10 is not triggered in the clotting cascade because again we don't have that factor VIII, and it ultimately prevents fibrogen from converting to fibrin, which is that cell, that definite clot. Sometimes we can have acquired, and acquired would be things like liver disease and vitamin K deficiency. The last one is DIC, or disseminated intravascular coagulation, and this is almost always a secondary response to some sort of primary insult. And basically it's bleeding and clotting together. They occur at the same time. So we get these small clots that develop in the bloodstream, and then all of our clotting factors and platelets get used up. So then we start to bleed everywhere. So prothrombin is activated, and our thrombin is produced in excess, and we know that thrombin converts fibrogen to fibrin, and fibrin clots in the micro circulation. So, and then the thrombin causes the fibrin clots to dissolve, and this causes hemorrhage. So if you look here, and primary things that can cause this are infection, people who are septic, pregnancy, trauma, burns, and shock. So again, similar to the coagulation cascade, we have an intrinsic and an extrinsic, and all of that produces thrombin generation. And then the thrombin does, 3 different things. It causes intravascular fibrin deposits. It causes the activation of plasminogen, and it causes an increase of platelet consumption. And then if you look on the left side of the screen, so we have that intravascular fibrin deposit, which causes thrombosis, which leads us to tissue ischemia and hemolytic anemia. So that is our clotting. And then in the middle, our plasminogen converts into plasmin, and then we get fibrinolysis, so it's going to attack the fibrin. And so our fibrin degrades, and it inhibits our thrombin and platelet aggregation, which is going to cause bleeding. And on the right hand of the screen, so we have that increased platelet consumption, which leads us to thrombocytopenia, which ultimately leads to bleeding. So it is very hard to treat because you have to try to treat bleeding and clotting at the same time, and it often carries a high mortality rate.